Good morning, all. I'm Lieutenant Commander Matthew Carr, Research Fellow at Scripps Mercy Hospital. First off, I want to thank SAGES for allowing us to present our work today, the fragmentation of care in the blunt abdominal trauma patient. I have no disclosures. I'm a member of the United States Navy. My views are my own and those of my authors only. They do not reflect the views of the Department of Defense, U.S. Navy, as well as the U.S. government. So trauma patients are at a very high risk of readmission, as we all know. These can be life-changing injuries that involve multiple organ systems and will require long-term care. As patients are typically treated at trauma facilities, which may differ from where they receive their primary care, they may present for readmission to a hospital other than where their trauma took place. We define this as fragmented care, wherein a patient presents for readmission at a hospital other than their index trauma facility. Overall, this is very difficult to study as you cannot always track readmissions to hospitals outside of your own hospital system, and they may go unreported. This has been researched in other populations outside of trauma, such as the primary care setting. It's been defined as care spread across multiple providers without a dominant provider or a large number of poorly coordinated providers. Literature from the primary care world has discovered that fragmented care in the outpatient setting has led to twice as many radiographic studies and other diagnostic tests as patients with the least fragmented care, as well as increased number of ER visits and overall increased costs. There exists a lack of knowledge within the trauma literature, specifically about the rate of fragmentation when looking at blunt abdominal trauma patients. The goals of our study were to objectively measure the readmissions to hospitals other than the index trauma facility. We then set to look for risk factors and protective factors against fragmentation. So our data, I apologize, I went a slide ahead, but our data originated from the California Office of Statewide Health Planning and Development, the OSHPD Patient Discharge Dataset. This is a data set which contains all patient records from licensed non-federal California hospitals mandated to report all hospitalizations. Data included the demographics, the admission factors, the discharge dispositions, and the diagnoses and procedures coded using an ICD-10. The study population consisted of all patients greater than age 15 who were diagnosed during the index admission with a blunt solid abdominal organ injury and had at least one readmission. Blunt solid abdominal organ injury was defined as non-penetrating trauma to the spleen, liver, or kidney. We did exclude pancreatic injuries as well as penetrating injuries, burns, death at the index hospitalization, or transfer during the index admission. Patients were grouped into fragmented or non-fragmented patients upon readmission at 1, 3, and 6 months post-discharge from the index hospitalization. Secondary outcomes included the overall rate of in-hospital complications and specific complications at both the index hospitalization as well as readmission. These were need for reoperation or reintervention, hospital length of stay, mortality, and discharge status. In-hospital complications included pressure ulcers, catheter-associated UTIs, DVTs and PEs, pain, malnutrition, wound complications, surgical site infections, GI complications, anemia, blood transfusions, infection, and sepsis. Descriptive statistics and univariate analysis for key variables and outcomes were calculated using a t-test, a Wilcoxon, and chi-square tests. Logistic regression modeling was used to evaluate odds of fragmented care associated with clinical injury characteristics. Overall, there was no demographic difference in the patients between the two groups. Of the 1,580 patients who met our criteria, nearly half, at 47.6%, were readmitted to hospitals other than their index trauma hospital, and this represented fragmented care. When breaking this down into 1, 3, and 6 months, we see that the fragmentation rates were 40%, 49%, and 53% respectively. When evaluating what was protective against fragmented care, we did note that operation on your index admission was protective and had a lower likelihood of fragmentation. Fragmented care was not independently associated with either demographic or insurance characteristics. However, multiple readmissions greater than 1 month out after the index facility discharge, and discharges to a non-medical facility such as a jail did increase the likelihood of being readmitted to a hospital other than your index trauma hospital. We evaluated a large number of complications as the admitting diagnosis for readmission, and we found that surgical procedures, wound complications, infection, and abdominal surgery were more frequent at readmission for non-fragmented care patients. UTIs and anemia were more frequent amongst fragmented care patients. Our two readmission diagnoses, which represented fragmented care, that was the UTI as well as anemia, were also the most frequent reasons for readmission overall at 1, 3, and 6 months. So blunt trauma comprises a majority of all trauma admissions, and our study is the first to our knowledge to evaluate blunt abdominal trauma. Nearly half, at 47.6% of the readmissions identified, were fragmented care. Our rates of fragmented care at 1, 3, and 6 months post-discharge were 40, 49, and 53% again. This exceeded that was been reported in the trauma literature, which is 11.1, 21, and 29.8% at 1, 3, and 6 months post-discharge amongst all trauma patients, not just blunt abdominal. Overall, this does matter outside of just idle curiosity when we wonder whatever happened to a certain patient. As mentioned, other specialties have taken objective looks at fragmented care and found that it increases ER visits, increases redundant and unnecessary imaging and lab work, departures from clinical practice guidelines as well. While we did not look at cost, we suspect this is an area where significant expenditures may occur, which may be prevented. Our data suggests that those who undergo operative management of their injuries are less likely to experience fragmented care. We all strive for this with adequate follow-up in our operative patients, so this was a reassuring find. However, risk of fragmented care is increased in non-operatively managed patients, and this may be an area of future focus for future interventions. Unlike previous literature on fragmented care, we did not find a relation to the type of insurance. Perhaps this is due to uninsured patients not covered by Medicare or Medi-Cal being underreported. The limitations are similar to all database studies. We're in retrospective in nature, and overall it does not include the granularity needed to identify all the variables which may reimpact readmission and fragmentation rates. This is also limited to hospitals within the state of California. So in conclusion, this is a very real problem that exists in the trauma follow-up world. I personally am very happy to note that we do a great job with following up long-term care with those patients that we operate on, but there is still room to grow with our discharged patients and follow-up in patients that we treat non-operatively. I would like to again thank SAGES for their gracious offer to let me present the work of Scripps Memorial Hospital, or Scripps Mercy Hospital. This is a view of our facility. In fact, we give this picture to every one of our discharging patients so they know exactly where to come back for their follow-up care. With that, I'll take any questions.